My name is Terry Mamounas. I'm the medical director of the Comprehensive Breast Program at Orlando Health Cancer Institute in Orlando, Florida. So in oncology, particularly for early stage breast cancer, there are different ways of assessing response. We typically talk about clinical response, and we also talk about pathologic response. So clinical response can be assessed either by palpation, and traditionally that was the way that we assessed it, palpation of the primary tumor and see if that is getting smaller. But also today we use imaging to assess clinical response, so either mammographic size, MRI size, or ultrasound size. So the difference between partial and complete response obviously is that in partial response, there is still evidence that the tumor is still present in the breast, at least clinically first. And we can do that by feeling that the tumor is still palpable at the area that was palpable before, versus a complete response where the tumor becomes non-palpable. In terms of imaging, the same thing applies. The tumor is visible by mammogram, ultrasound, or MRI. In a partial response, it gets smaller, but it's still visible. And in a complete or clinical complete response, or imaging response, if you like, the tumor essentially becomes not visible anymore by either one of those modalities. So this is the clinical assessment of complete response. And that obviously has also some implications in terms of the surgical management, given that obviously we give neoadjuvant chemotherapy or neoadjuvant endocrine therapy, often with the intent of shrinking the primary tumor and actually performing a less extensive surgery, converting potentially an inoperable patient to operable candidate, or converting a mastectomy candidate to a candidate for breast conservation. Or let's say if the tumor is very close to the nipple that requires nipple removal, we can push the tumor away and make the tumor smaller and potentially preserve a nipple without affecting the margins of resection. So this is why we do it clinically. So obviously, there is a difference between clinical complete and clinical partial response in terms of the surgical option sometimes, because if we still think there is evidence of the tumor, the patient may not be amenable or a candidate for a lesser procedure. However, if we do shrink it enough, even with a partial response, the patient may have less extensive surgery. So that's a clinical judgment that we follow in these cases. In terms of pathologic response, that means what the pathologist sees under the microscope after we give neoadjuvant chemotherapy and take the patient to surgery. And again, here, obviously, the very important point is pathologic complete response. And that essentially is a definition which says is not to find any invasive tumor in the breast after neoadjuvant chemotherapy or neoadjuvant endocrine therapy, or to only find non-invasive tumor. So in other words, either finding nothing, that will be a pathologic complete response, or finding only non-invasive disease is also considered a pathologic complete response. And the outcomes between these two situations are actually very similar. That's why we call it a pathologic complete response. If there is presence of invasive disease, then there is obviously residual disease, and we consider that a partial pathologic response. There are also some different tiers of residual disease. For example, one of the classification factors is what we call residual cancer burden, that takes into account the response in the breast and response to the nodes. And the residual cancer burden 0 essentially is equivalent to the pathologic complete response, and then partial response will be equivalent to residual cancer burden 1, 2, 3. So that also obviously has prognostic information, because patients with pathologic complete response have a lot better outcomes than patients that don't have a pathologic complete response, and clearly has surgical implications as well, because if we believe that there is an imaging complete response and we think there's going to be a pathologic complete response, we can certainly minimize, let's say, the size of lumpectomy resection. We can feel more comfortable about the margins, and as long as that is confirmed on the final pathology specimen, then obviously we have achieved something by giving neoadjuvant chemotherapy, by doing less surgery. And that's true, of course, in the breast, but it's also true in the axilla. In the axilla, same thing. We can have lymph nodes that are enlarged and that become normalized. that has clinical implications. This is considered a clinical complete response in the nodes, because if a node was positive before and biopsy proven, but now it normalized by imaging and by palpation, it disappeared as a palpable lymph node, then, for example, we'll proceed with a sentinel lymph node biopsy, whereas the patient would have required an axial lymph node dissection if the node did not respond. If we feel that they responded partially, but we still feel the node is palpable and looks abnormal on the ultrasound. Similarly, if the node becomes then pathologically negative and we do a sentinel lymph node biopsy and the node has no disease, then that has surgical implications, because we do not usually complete an axial dissection in these cases. We give the patient the benefit of the doubt, saying that the remaining nodes also will have been sterilized, so we can do less surgery than originally planned. So these are some of the surgical implications, both in the breast and the lymph nodes, of a clinical complete and clinical partial response, or a pathologic complete response, or a pathologic partial response, which essentially means residual disease.